Okay, well, welcome everyone. In this session, we're going to try and work our way through some more of your questions that have been submitted during the day and in advance. Where possible, I've merged some of the questions to pick up on the main themes. I think that collectively our speakers have dealt with around 100 questions already, but we have had about 400 submitted, so we are not going to get through them all. I would really encourage you to review the videos of all of today's sessions, which will be available on our YouTube channel from next week. We've also got the script of last year's Q&A on this platform, and that's well worth a look. Remember as well, you can always visit the Cardiomyopathy UK website or call our helpline to speak to one of our nurses. So really, there are all those opportunities to get your questions answered. So I'm pleased to say that joining us today, we have Dr. Sam Mohiddin, Professor Perry Elliott, Professor Ruth Newbury-Ecob, and Dr. William Bradlow to help answer our questions. And I'm going to kick off with a good one to start with. It's, does HCM or indeed any type of cardiomyopathy only affect the heart? What about the impact on other organs? If you've had a transplant, has the effect of cardiomyopathy gone? Perry, do you want to start us off on that one? Okay,
so hypertrophic cardiomyopathy doesn't generally affect other organs except in maybe the late stage of the disease. So like any cause of heart failure, you can get secondary effects on other organs, particularly the kidneys, for example. The only slight hesitation in my answer is that, of course, there are what we call phenocopies of the disease, which can be multi-system. And this came up in certainly a couple of talks I did. So if someone may present with a thick heart, and that could be, for example, caused by a disease like Fabry's, which is rare but is often multi-system, amyloidosis, which again can affect other organs. But for the sort of hardcore HCM sarcomere protein disease, then generally other organs are not affected, so, unless you have advanced heart failure.
Brilliant. Does anyone want to add on to that?
Just that it's a slightly different story in children, so that we definitely see hypertrophic cardiomyopathy as part of wider genetic syndromes, and they may well affect different parts of the body in different ways. So depending on the particular etiology, so for example, if we see cardiomyopathy as part of Noonan syndrome, we might see an effect on stature or on the kidneys. So I think there's a difference there between we would call it isolated hypertrophic cardiomyopathy and the syndromic causes that are very different.
Brilliant. Okay, well, sorry, go on.
No, so you asked about transplants. So again, for the non-syndromic multi-system forms, once you had a transplant, that's the end to the Hogan story. It's a new chapter opens up with the transplant.
Okay. Okay, we had another question. I might ask you, Ruth, to start us off on this one, if that's all right. It's how can we make sure we get genetic testing, and how often should we be retested?
Oh, very good question. So how to have it? Well, the main thing is that you ask. And I know that cardiologists are very busy people, and they've got an awful lot to do in their appointments, and they may not instigate that as an issue. So it's really good if families ask. About retesting, that's very difficult to be very specific. But I think if your family have undergone genetic testing, anything over 5 years ago, I would definitely say, is this a good time to review using newer technologies? If it's been done in the last few years, that may be less appropriate, but certainly anything over 4 or 5 years.
It'd be interesting what the others. I mean, Ruth, this came up a couple of times in the questions about the whole issue about recall. As we keep chipping away with new genes, and I think one of the problems that we face in certainly some of the sort of busier services is that just logistically, that's a big undertaking to start recalling people. I mean, even being able to track people to recall is quite an issue. And I know in the past we've talked about this and drawn analogies with cancer, but do you have any views on that?
I think we've adopted what we call the point of care model, which is that we don't actively recall families unless we are made aware of, for example, a reclassification of a variant, and we have been doing that. We've been contacting families proactively where laboratories have recalculated and feel that something is more likely to be significant than before. But otherwise, we would say at the point of care. So that is at your cardiology appointment, or at, and it may even be in a primary care setting, to look at it, and for clinicians to do the same. So if you're going to use that information, if somebody's coming for screening, or if you're giving advice about other family members, or referring somebody in a pregnancy, that's the time to reevaluate the genetics.
Ruth, can I
It's
add?
incomplete, but it's balancing, I think, the availability of resources with making sure that those resources are targeted to the sort of more critical times when that information is going to be most valuable and used. Sam?
To Perry's question there, Ruth, and an associated issue is testing people for newly detected genetic causes that are associated with bad outcome. So let's say in the last 10 years, we've learned a lot about DCM and some of the genetic abnormalities that are associated with really poor outcome that are actionable. But many of these genes weren't tested on the panels that were previously available. As we move into mainstream gene testing, shouldn't that be checked for automatically? That kind of thing be checked for automatically?
Yes,
without a need
absolutely.
for recall?
Yeah, and I think that would be point of care, because presumably these are people who are still within the system. If they are affected, they will be undergoing regular review with somebody or not. Do you think they might be outside of the system completely?
I think that's the challenge, isn't it? I mean,
Yeah.
Okay, yeah.
I mean, I don't know whether Will wants to. I mean, it's different, as you say, if they have the disease, but the problem is exponential growth in follow-up populations.
Yes, yeah.
So if you have someone who's essentially well with well-controlled DCM on good therapy, the implication behind the point of care model is that you have to keep seeing them in a point of care that is maybe just sort of genetically literate and has access to genetic testing, which of course is becoming a bigger challenge.
I think this is much more of an opportunistic model rather than setting out for more formal review when new genes are identified. I think that hasn't been, I don't think that's been resourced. I think the resources at the moment are targeted towards new diagnoses, or where there is a change in clinical presentation, or where there is a new event in a family, such as a new diagnosis, a new person comes forward, newly diagnosed, or events such as pregnancies.
I'm going to move on to the next question. I think to some extent the next question is a little bit related. It's, can an ICD procedure be reversed when medical advances make them obsolete? I suppose it's a similar question in that our knowledge and our ability to treat is sort of growing all the time. And so what do you do with people who you've treated and supported previously? How often do you come back and or take out a device? I'm going to start with you, Will, if that's all right. So we've got Will on the line, but we can't see you, but we can hear you.
Thanks, Joel. I think it's a great question. So I've certainly had experience of a handful of cases where on closer review of the original indication for why the ICD was implanted, the clinicians come together as part of a multidisciplinary team meeting, and they review all of the information, both the historical information, but what's been learnt in the meantime, and they might come to a different decision about what to do with that device. And that tends to crop up, particularly when the patient comes back in for a box change, and if the risks are not to extracting the device or are not felt to be substantial, or if the risk for the patient not to have the device in place is not felt to be greater than the benefit of leaving them without a device, then there may be a decision made not to replace the battery, or in some circumstances even to remove the battery and the associated hardware altogether. So those are decisions that are made regularly as part of a multidisciplinary team meeting featuring both the doctors looking after the cardiomyopathy, but also the doctors responsible for doing the devices in the first place.
Brilliant. Okay. Does anyone want to add to that one?
Yeah, I mean, I agree with Will. I mean, I think that scenario does crop up, but I think one of the problems in cardiomyopathy is that I think it's quite rare to reach a stage of the disease where you think the risk has declined. I mean, I think the original indications, as Will was describing, sometimes are reviewed, and with the benefit of new knowledge that's accrued and so on, you might make a different decision based on the same information. But I think in the majority of patients where you thought they were high risk 5 years ago, it's very hard to say 5 years or 10 years or 15 years down the line that they're not. And one of the arguments I think we often hear is that, oh, well, nothing has happened, therefore they're okay. But particularly in some conditions like hypertrophic cardiomyopathy, the first event after an ICD goes in might be 10, 15, even 20 years later. So I think it's very difficult to reach a stage when you say, no, you're okay.
Okay.
Can I add a little bit to that? And we're asking here whether or not it's in a patient's and an individual's benefit to remove a device. And so removal of that device itself is associated with real risks. And those risks may be greater than the risks of leaving a device where it is. In addition, the first decision to put the device in is about weighing benefits with downsides. And you've already paid for most of the downsides by putting that device in. So, I think unless there are really good reasons to take it out, one often ends up just letting it stay.
Okay. So I'm going to move on to the next question, if that's all right. It says, what are your thoughts on pregnancy and DCM? My cardiologist seems reticent, but I've been referred to a specialist clinic. I understand that there are factors to consider. I'd like to know your thoughts. So I'm going to assume that's someone who's looking to start a family with DCM. Sam, do you want to start us off on that one?
I avoided that one during the talk, I think.
Did you? Sorry. Well, it comes back to haunt you.
I know it's a really good question. I just hope the answer is as good as the question. I mean, there are a number of things here to think about in general terms, but the appointment that you have with a specialist is a really good place to start. And as another general principle, pregnancy in these situations are always better planned than not planned. The issues to consider in no particular order include the risk to you from pregnancy and childbirth, the risks to the child from the medicines that you're taking. Some of the drugs that we give for DCM are potentially toxic to a developing child. And number three, issues that relate to the likelihood or possibility, particularly if this is genetic, that the disease could be inherited by the child. I think those three things are the headline topics to discuss. And in the talk that I gave, I mentioned that this idea of anticipating lifestyle, livelihood, and life event issues, it directly does relate to things like pregnancy. So planning. Get involved with a cardiologist that has expertise in obstetrics or an obstetrician with expertise in cardiology. They often work in teams and planning, and discussing risks and benefits.
Ruth, is there anything you can add from a point of view of sort of genetics? If someone's thinking about starting a family and some of the, I suppose, the genetic considerations about their child, as well as obviously their own health?
Yeah, so in general, I mean, there may be options for testing during pregnancy. If a woman is planning to have a pregnancy, that may be an opportune time to undertake testing if it hasn't been undertaken previously. And that can give information about whether there is a risk to the baby. In terms of testing directly for pregnancies. There are options for pre-implantation genetic diagnosis. This combines genetic testing with IVF, and for standard prenatal testing that have been available for some time. And there are families who have taken that option, particularly where these are perhaps cardiomyopathy phenotypes that can be very severe in early life. So again, those a maternal medicine specialist working with a cardiologist who has an interest in pregnancy will be able to advise during the pregnancy, but pre-pregnancy, they would need to have contact with probably a genetic counsellor or a geneticist to find out what might be available.
Thank you, Ruth. I'm going to move to the next question. The question is, what can be done to make it easier for GPs to detect cardiomyopathy? It's quite a big question, I guess, and I think we've all probably got a part in that. Will, are you okay to start us off with that?
Yeah, absolutely. I think that's a really exciting question, in the sense it opens up enormous possibilities. If we could reach into an as yet undiagnosed group of patients who are affected, you would be able to pick out and treat those people who will go on to develop complications, accepting that there will be a large group who will receive a diagnosis but actually only need monitoring long term. So in terms of ways you can go about it, I think probably the most important is systematic screening. So that's following the guidelines that are available, the European ones, for example, from 2014, that say, you should be, the doctor should be taking a 3-generational family tree, and we should be recommending first-degree screening to look for the condition. That's the group where you're going to have the highest yield. In terms of opportunistic screening, there's quite a lot of options there available as more and more people have ECGs in the community, and there are going to be times when they're very abnormal, and that hopefully will be detected by the GP and referred on to a specialist who will then be able to assess the patient further. And then you have people who are presenting with symptoms of cardiomyopathy, and there I think it's as much about education within primary care as possible, ensuring that the GP is alert to the possibility that breathlessness or those dizzy spells could be more than, for example, just some anxiety.
Thank you. Does anyone want to add to that? So has anyone had any sort of experience of working with primary care in their area?
I think this is a really tough one, Joel. I think it always has been, because I think we have to understand it from the other perspective, from the general practitioner's perspective. I mean, cardiomyopathy fills our horizons, but it doesn't fill a general practitioner's horizons. Yeah, it's actually a relatively small part of what they do on a daily basis. So I think sort of trying to educate them to a high level about the individual diseases themselves, I don't think that strategy works. I think Will made an important point about symptoms. I think educating GPs about red flag symptoms, the kind of stuff that requires referral. So, unexplained syncope, for example, or chest pain and breathlessness, the kind of stuff that the charity has been sort of promoting. But I think to think that we're going to raise the bar in terms of understanding of cardiomyopathies, and certainly genetic literacy about, what is a genetic test and when do you refer and all this, I don't think that strategy has worked before. And I think a measure of that, even when people get a diagnosis, is that, a few years ago we did an electronic health record study, and a third of the patients with a diagnosis of hypertrophic cardiomyopathy had never been seen in hospital. So a third of those diagnoses were made in the community, presumably because of community ECGs or echoes or whatever, but they'd still not been referred on. So I think, there's some fundamentals I think we need to tackle, and I say it's about those warning signs. Even if you don't know what this is, refer it. Please refer it.
Do you think those barriers are money? Is it process? Is it ego? What sort of stops those referrals?
I don't think it's ego. I think it's desperation. I mean, I think it's not much fun being a GP. Yeah, I mean, I think that's what I mean. I think it gets lost in the noise to some degree. I don't know what the others think, but I do have sympathy for general practitioners. I think we bash them up a lot, but you could be equally having a conference on diabetes or respiratory disease or whatever. I mean, how can a general practitioner juggle all those things?
Yeah. Well, I think that you mentioned diabetes, and I think that might be an interesting area to go to next. But we had a question that says, if someone with HOCM develops type 2 diabetes, is the diabetes medication compatible with their treatment? I think it might be worth just sort of broadening that out a little bit to talk about diabetes and cardiomyopathy and diabetes medication as well, if that's okay. Perry, can I ask you to start with that, if that's okay?
Yeah, so there's a number of different ways of looking at that. So depending on the cardiomyopathy, diabetes may be part of that mix that has some influence on how the disease expresses itself. As we discussed today, a number of different talks, I think, if you have dilated cardiomyopathy, having diabetes is not a good thing to have if it's poorly controlled. The drugs that, particularly for type 2 diabetes, I mean, we have the interesting coincidence now of management of heart failure and management of diabetes with a whole new class of drugs called SGLT2 inhibitors, which are effective in diabetes, but also now have been shown to be effective in people with heart failure, irrespective of whether or not they have diabetes. In terms of the other drugs that are used, I can't really think of any major interactions. Sam, can you? I mean, SGLT2 inhibitors come with their own baggage, but...
Yeah, the SGLT2 story and the heart is interesting. Essentially, the big European EMA and the FDA required the pharmaceutical companies to do cardiovascular outcome studies on this class of medicines, the SGLT2 medicines. And they asked for that because prior new classes of anti-diabetic medicine were associated with poor or adverse cardiovascular outcomes, particularly in heart failure. Perry, you'll remember the PPAR gammas and that story. And it became apparent during those cardiovascular trials that not only weren't SGLT2 drugs not causing worsening disease, they actually were reducing quite dramatically, reducing heart failure admissions and complications, even in people, it turns out, who didn't have diabetes. So it's a really happy coincidence, and we don't really understand why this is, but it's a great new area. It's a great new area of hope for therapy. I think in general, diabetes has such a profound effect on metabolism, on renal function, on cardiac function, that the interactions mean that good control of diabetes is an essential component of the holistic approach to someone with heart disease.
Okay. I think we've lost Ruth momentarily, but I'm sure she'll pop back in. I'm going to move to the next question. Is there anything that we know now about ARVC or ACM that we didn't know a year ago? I'm prepared to make that 5 years ago, just to make it a little easier. Perry, why don't you start off with that one?
Stuff that we can put in the public domain. So I think in terms of risk stratification, I think that's moved on a bit. As you know, I think there's a general move to try to develop risk tools that allow you to estimate a risk and use that in a conversation with a patient with the disease to make a decision about whether or not an ICD should be put in. So there is now a risk tool for arrhythmogenic cardiomyopathy. A couple more genes have joined the list. I think I think one of the issues over the next 2 or 3 years is going to be in nomenclature, because we've got a bit of a mess now in terms of what we call things. So there's classical ARVC, which we've been talking about since the 1980s, and then there's a whole bag of stuff which has been sucked up into that, arrhythmogenic cardiomyopathies, and for a number of different reasons, because pure ARVC is quite rare. A lot of people also have left ventricular involvement, and it's also been used as a catch-all for some of the other forms of cardiomyopathy, dilated cardiomyopathy and so on, which are associated with a lot of arrhythmia and a high risk of sudden death. But as a consequence, we've ended up with this rather unwieldy concept. So I think risk stratification is getting better. I think we need a bit of a tidy up in terms of the nomenclature, because we're actually dealing with a family of quite different diseases.
Brilliant. I think Ruth's back with us. I'm actually going to move on to the next question. Unless anyone wants to jump in on ARVC. No? Okay. So we had quite a few questions relating to gene therapy, which I think can probably all be summed up to sort of what is it and when can I get it, and sort of how realistic is that. Ruth, is it something that you've had in contact with, sort of gene therapy, or what's your views on it at all?
No, not at all. I guess there's a very, very limited amount of gene therapy. It would definitely be for the cardiologist to comment. What I would say is that actually gene therapy, I think, is not the major direction of travel for research using genes. Gene identification is facilitating identification of appropriate drug therapies, so targeting drug therapies according to your genotyping. And as well as the studies that are underway at the moment to find causative genes, there are the studies that are looking at the background genotypes that people have in relation to the way in which they handle drugs, for example. We know some people respond very differently to drugs like warfarin. So this sort of personalized medicine, stratified medicine centered around pharmacogenetics and pharmacogenomics is a big story. And we have some involvement in that because we're involved in the gene identification pathways. If you have your gene, you're halfway there. Half of your £6 billion budget, £6 million budget is already accounted for if you have your knowledge of your gene. But this isn't the same as gene therapy. Gene therapy is something very, very different and very specific.
Yeah, Perry, I know you touched on it a little bit in your session, but just for those who weren't there, can you just do a very quick summary of what do you think people actually mean by gene therapy, and how realistic are we talking?
Okay, so as I said, there's a huge amount of investment and time being expended by drug companies now in gene therapy in its broadest sense. As the ultimate is to say, well, this person's got a genetic defect, we're going to correct it. So we're going to restore the genotype within the heart tissue back to normal, and therefore potentially cure the disease, I suppose. And that approach is being investigated through a variety of different mechanisms. It's a significant challenge. So, for example, some people that have particular genetic mutations, which mean they don't produce enough of a particular type of protein in the heart, it is theoretically possible to introduce a normal copy of the gene into that cell to restore the protein levels. The question is, how do you get that normal gene into the cell in the first place? And a variety of methods being explored there. One is to use a virus, what's called an adenovirus, AAV, in which you attach part of the gene and then use the virus to take it into the cell. And that's an approach which is being used therapeutically in other areas. For example, in haemophilia, it's been tried in neuromuscular disease. It's been tried in Fabry's disease, at least in phase 1s. The problems are the heart just doesn't like, despite everything we hear about COVID and all the rest of it, the heart doesn't like taking viruses up. It's actually very hard to get the virus in. If you use really high concentrations of virus through a peripheral injection, then that can initiate a really quite severe immune response. So often with AAV therapies, you actually have to immunosuppress the person receiving it, because otherwise they can get liver toxicity, they can develop thrombosis. And so various approaches are being explored in which you can deliver it directly to the heart, down the coronary arteries, backwards up the coronary sinus, direct injection. All of these things have particular issues. Other than AAVs, other platforms are also being used, which are perhaps less toxic, but the delivery is probably the major issue, I think, in terms of gene delivery. Other ways are to change the way in which genes are expressed. So you can turn off genes, you can sort of bypass abnormalities in a gene using RNA technologies, and again, that's being used in other settings. It's the same issue about how you get it into the heart, but the toxicity issues are probably less. And then it's not really gene therapy, but by better understanding of the pathway, I think this is Ruth's point, you can actually use genes guided by the underlying genotype to correct the downstream effects of that gene. So there's a lot of talk about what we call small molecule therapy. And that is probably where the best options are at the moment. So mavacamten, we've heard a lot about. That's essentially a small molecule to deal with the downstream effects of a genetic abnormality. And the same approaches are being explored in other diseases as well. So I think there's a lot of things in the bag. I mentioned gene editing as well. I don't know what Ruth thinks about gene editing, but it's been proof of principle in amyloidosis. But that's because it's relatively easy to get the machinery to do gene editing into the liver, which is the main source of the problem, rather than into the heart again. But we only need one or two of these things to work. They won't all work, but if one or two of them work, that's an incredible step forwards.
Okay, I'm actually going to move on to the next question, if you like, just so that we can move through quite a few. We've had quite a few questions actually about hormone therapy and its impact on cardiomyopathy. I think particularly DCM. Is anyone able to sort of talk a little bit about what we know about hormone therapy? Anyone who says, Perry, you can start.
No, I was going to say Dr. Bradlow. Dr. Bradlow is not having his face on the screen. Lets him off too easily, I think.
Okay.
Are we talking hormone replacement therapy?
Yeah, HRT. Okay. Yeah.
So I'm not aware of any association with detrimental outcomes in people with existing cardiomyopathies taking HRT, but I'll be glad to be corrected if that's not the case.
I mean, where you have a risk of thrombosis. So sometimes, for example, in patients with dilated cardiomyopathy, or if they've got atrial fibrillation, then if HRT, as Will said, there may be a theoretical risk, but the risks are probably outweighed by the benefits of HRT. There is sometimes an issue with use of contraception, oral contraception, and we tend to go for progesterone-only options or barrier methods rather than estrogen-containing preparations. But for HRT itself, as Will said, I'm not aware of any major contraindications. Are you, Sam?
No, it would be helpful to know the context for that question. It sounds like there may be a story here that we could explore a little better. And as you suggested earlier, Joel, this may be one for responding to offline. I'd like to know more about why the question is being asked. I don't know of any specific features, the procoagulant issue aside.
I think there was a number of questions, but I think there's one that's got a bit more detail, which says, as a perimenopausal woman with DCM, I noticed that my symptoms are worse when I'm ovulating, menstruating. Is HRT recommended for women with heart conditions to help maintain heart health? That was the sort of the broader question. There's quite a few about this issue, I think.
I guess there may be questions or issues with regards to fluid retention in situations like that, but I don't know of any specifics.
I think it's more a general women's health issue rather. I mean, I don't think it should be withheld because of a fear of interfering with the cardiac disease. But I think as always, it should be discussed individually related to the severity of the condition. But I don't think it shouldn't be withheld for that reason.
All right, I'm going to move on to another one. It says, I have an EF of 27% and I'm tired. Is it because of the medication or my heart failure? It might be worth just explaining to everyone what we mean by ejection fraction and what the numbers mean as well. Sam, do you want to start off on that one?
Yeah, happy to take that. We covered some aspects of the ejection fraction, or EF, in the DCM talk, but EF is one of the ways in which we try and quantify the severity of contractile or muscle impairment in the heart. And an ejection fraction of 27% would place a heart into a category that we would consider as severely impaired. There is an association between the severity of impairment of the contractile function of the heart and symptoms. It's a very good correlation if you look at large populations. But there are many people who have very bad symptoms and ejection fractions that are much better, and vice versa. That being said, the symptoms of fatigue could very well be attributable to heart failure. And we do also know that some of the medicines that we give for heart failure, and we give them to people with heart failure for the purposes of making them live longer, not for the purposes of making them feel better only. And some of these medicines can cause side effects, like fatigue, and particularly the beta blockers. It's also important to look for other things that could be contributing to symptoms like this, anemia, thyroid function, and so on and so forth. So the answer is yes, it could be due to the medicines, but I think you'd have to be very sure that it wasn't due to anything else. And the advice would be to persevere and take the medicines unless the side effects are very severe, because of the ability of these medicines to improve the future and lengthen lives.
Thank you. Does anyone want to add to that?
Joel, do you mind if I just
go for it? Sure.
I think another thing to explore is so one thing is specifically sleep related problems. So thinking about something called obstructive sleep apnea, where the quality of sleep overnight is very poor, even though the person's apparently sleeping, because over the course of the early hours, they're repeatedly obstructing their airway, so they get the oxygen delivery is affected, and that typically presents with sleepiness during the day. In fact, sometimes so severe that people can fall asleep during mid-conversation. Things like morning headaches might be a clue to that as well. I think another couple of issues that are worth raising are the sort of person's sleep hygiene. So when are they going to bed? When are they waking? And how often are they waking during the night? And shift work, night shift work, for example, will play into that, because generally speaking, people sleeping during the day get less sleep than if they were sleeping at night. So that's really important to explore as a cause of fatigue, because it might just mean some lifestyle adaptations. And on the lifestyle front as well, tiredness could be a manifestation that person is doing less than they were before, not because they're necessarily limited by the heart, but over lockdown, I'm sure everybody, I certainly did, put on a little bit of weight and was doing less. And that sort of behavioural change we've experienced over COVID can itself produce symptoms like tiredness.
Okay, brilliant. Thank you, Will. Okay, I'm going to move on to the next question. It's a COVID-related question. It says, can the COVID vaccine worsen cardiomyopathy? What is its link with myocarditis? So probably good opportunity just to discuss that, if that's all right. Perry, do you mind kicking off on that one?
Well, I'll maybe do the first part of that. Perhaps ask Sam to do the myocarditis question.
Okay.
I think the first one is part of my. It's become a bit of a scratch record now, but it's. So I think at the beginning of the COVID pandemic, I think there was a great fear that people with cardiomyopathy were going to be more vulnerable to the effects of COVID, and that, if you do the thought experiment, that's entirely reasonable. You've got a virus which could potentially cause inflammation in the heart. It's going to affect the clotting in and therefore cause blockages in arteries and veins. It may, by inflaming the heart, make it more vulnerable to arrhythmia. And if you've already got a heart which is already vulnerable to those things, then you don't want to have the two coming together. I don't think during COVID we saw this epidemic of people with cardiomyopathy being admitted with problems, but that of course could simply be because the work of the charity and others meant that people with cardiomyopathy shielded very effectively, so therefore were not being exposed. But at least anecdotally, and I don't know whether the other guys have also seen this, I've had quite a few people with cardiomyopathy that did get COVID, And just as in the general population, there's no rhyme or reason behind it. Some had really bad disease and others barely touched them. So I think having cardiomyopathy itself, I think theoretically increases your risk. And you really don't want to have the two things going together. So have your vaccine. There is no argument not to have the vaccine, because I think you're taking an unnecessary risk. But I think the interaction perhaps wasn't as deadly as we might have anticipated at the beginning. Sam, would you agree with that?
Yeah, absolutely. There are a number of stories to unpack in the whole COVID and the heart, and you've done just that, Perry. You've I think described that quite well. There is this idea of pre-existing conditions increasing vulnerability to any illness, and it seems particularly so in COVID for reasons that I'm sure we'll understand better in the future. And some of those reasons may be because COVID can affect the heart directly. It can be because of the immune response to COVID also has an effect on the heart. I don't know of any data that says that the reason that you have cardiomyopathy makes it more likely for you to have bad COVID. But there's good data that suggests that people with heart failure are more likely to do badly if they get COVID. They're more likely to be admitted, more likely to do badly when they're admitted.
Yeah. As you say, I think the conditions, the common conditions which clearly predisposed were things like hypertension, diabetes, obesity, those common traits. And there could be a common connection between those things. Yeah.
I mean, a lot of people who have diabetes will have hypertension and may have a bit of
and the genetic predisposition, the demographic that is prone to those things may also be prone to COVID.
Yeah. And obesity was a surprising but very strong signal too, wasn't it?
Yeah.
Isn't it? I suppose.
Yeah.
The second question was about myocarditis, and this is I also an important topic. It's also become quite political. I think, as Perry said, that the virus is worse than the vaccine in almost every situation. I can't think of any way it's not. So take your medicines. For cardiomyopathy, socially distance, wash your hands, and get vaccinated. There is unquestionably, I think, a signal that some people will get a form of myocarditis after vaccine. The signal suggests this is more likely to be an RNA vaccine than other types, and that most often it occurs about a week or so after the second dose of that vaccine. And in people where it's occurred after the first dose of a vaccine, it's more likely they've had the infection already. So it's the second exposure. Most of the early reports were with the RNA vaccines, but I think there's also a good signal that AstraZeneca is associated with myocarditis. But there's another important aspect, which is that most people who've had myocarditis have been male and young, and they have very mild self-limiting disease, which is what most myocarditis is. And I suspect that we will learn a lot about why people have myocarditis in general terms because of what's been happening with the vaccine.
Brilliant. Sorry, Sam, to cut you off. We've only got another couple of minutes, and I was trying to get everyone to answer this last question. And we'll start with you, Ruth, if that's all right. Thinking about cardiomyopathy in 10 years' time. So let's say we're still here in 10 years, hopefully not online, but in person. What are you most excited about for cardiomyopathy in 10 years' time? Ruth, if you don't mind, you kick us off, and we'll. Oh, you're on mute though. You're gonna have to.
Yeah, come off. Well, I suppose that the hope is that with the availability of genetic testing, that every time anybody is diagnosed with cardiomyopathy, they can have genetic testing if that's what they want, and that will give them the best options in terms of their treatment, but also the best options for their families in terms of wider screening. I think one of the things that we haven't really touched on is before in our discussions about genetics is that as genetic testing becomes more expensive and more comprehensive, people will be being identified as having a susceptibility or a predisposition to cardiomyopathy much earlier in the pathway. So this will come out when they're having genetic testing, possibly for even a completely unrelated reason. So and that also will bring them the opportunities for the earliest interventions, which one hopes will produce better prognosis and outcomes.
Brilliant. Will, very quickly, how optimistic are you for the future? How are things going to be in 10 years' time?
So, Joel, you know I'm a natural optimist. My hope is that I think that the systems work together so that the patient experience along the entire pathway is smoother, not just for them, but also their family. And I'll leave it at that.
Sam, what about you?
I'll say what Ruth said, and it's about the idea that these diseases are the result of lots of things happening, not just a genetic thing. So it's about mechanisms and understanding why cardiac damage develops in susceptible people. And I suspect that we'll find that inflammation, amongst other things, plays an important part of that.
Brilliant. And Perry, we're going to finish with you. I mean, and I mean this in the nicest way, but you've been around cardiomyopathy for quite a while. I mean, if you think about how things are now compared to sort of 10 years ago, 20 years ago even, and the next 10 years, are you optimistic? Are you hopeful?
Very. I think it's chalk and cheese. I mean, I think if I look back, it's almost 30 years now. And, you know, the kind of things we've been talking about today weren't even a twinkle in the eye of people 20, 30 years ago. So, you know, we're talking about families of different diseases caused by different mechanisms, different genes. And what that's created is the possibility for precision personalized medicine. And as Ruth said, prevention. You know, I think if you know the cause and you have a predictable disease natural history, it means you can start initiating therapy before you have irreversible damage in the heart. That to me is the really exciting thing, is that actually we can get genuinely into preventative medicine in cardiomyopathies.
Brilliant. I'm going to leave it there on that very positive note. And I just want to thank all our clinicians for everything they've done throughout the day as well. It's hugely appreciated. As I said before, if we haven't got around to answering your direct question, do apologise for that. But do give us a call on our helpline, which will be open from Monday morning. And we're going to leave it there. Thank you.